Welcome. I'm Richard Fox. Thanks a lot for coming by this evening. We hope we can make this interesting for you. We're going to talk about memory loss and some recent developments in prevention and possibly even reversal of that process, and the role of genetic and lifestyle factors in that process. If we could have the next slide, please. Oh, I guess I have the.
You have control.
I have the control. All right, let's try it. Just quickly on my background. I'm not a neurologist. I'm much more interested in metabolic disorders. As you can see, I've been in academia at an earlier point in my career. I've had some research fellowships from the American Heart Association, Lung Association, National Institutes of Health. So, and I have 24 published papers in peer-reviewed medical journals and quite a few abstracts and presentations at various medical meetings. So we're going to talk about this tonight. There'll be quite a bit about our understanding of some of the science and metabolic aspects of memory loss. And don't worry if this seems a little difficult, because a lot of this would be difficult even for a room full of doctors. So there won't be a quiz on this at the end, but mostly I want to show you that there's quite a bit of science behind this work that we're interested in doing. And that it's not just a fairy tale. So I think some of my doctor friends are skeptical that there's really anything to offer for this disorder. And we'd like to show you that there have been advances in understanding this, and we hope in having something to offer. But first, on a more human side of things, memory loss, dementia, is getting to be a horrendous problem in this country. And we'll talk about the widespread nature of this problem in a minute. But one of the things that it does is it challenges us at a very personal level more than most other diseases do, because it's frightening. It's frightening not only for the patient, but for the family. And requires a great deal of courage to deal with this problem. And one inspiring person, of course, in that area is Ronald Reagan, and of course Nancy Reagan. And as so often happens, when one family member is stricken with this, the burden falls on the rest of the family, in this case on Nancy Reagan. A word on the incidence of dementia by race, which is quite striking. In the Caucasian population, it's quite widespread by numbers, but you can see in the Hispanic population, and especially in the African American population, quite a bit higher incidence. Now, whether that's on a genetic basis or different lifestyle factors, I don't think we know the answer to that. But it certainly illustrates the challenge that we face in this area. And of course, huge differences by sex. Something like 3/5 or as much as 2/3 of the patients with dementia are women. And they seem to have some of the more severe varieties of dementia. And they also end up, if they're not the patient, they end up bearing the burden of taking care of another family member who does have this problem. So women are affected by this both as patients and as caregivers. And in fact, the view of the Alzheimer's Association is no cure. Very discouraging if you have a family member facing this problem. The drug companies have spent hundreds of millions and perhaps even in the billions of dollars trying to develop drugs for this. This from January 6th, Pfizer determined that their drug was a total failure, it was a flop, and they pulled all their money out of dementia research altogether. They're not going to fund any other drugs. They're done. So the other drug companies have had similar lack of success in coming up with anything that really works for this. So everyone knows someone who is a cancer survivor, but no one knows an Alzheimer's survivor. At least until this book came out and this work, which has emerged in the last couple of years. Dale Bredesen is a professor of neurology at UCLA and has been studying the metabolism and molecular biology of Alzheimer's disease in a test tube for 20 or 25 years and believes that he has now come up with a solution, or at least potentially a solution. It's interesting, he did not develop a billion-dollar silver bullet drug. His approach is actually fairly inexpensive, using medicines, both prescription and even non-prescription, that you can already buy at Walgreens. A totally different approach to the problem. And in fact, I think that's been a hindrance because no drug company wants to give him $500 million to develop this because they can't make that kind of money on his program. But it's good for the rest of us because we can start using this without having to wait for all that research to be done. So that's Dale Bredesen. I had the opportunity to go to a weekend conference that he did in Dallas in September to hear him talk about this at length. In fact, he sat next to me for a little while. I had a chance to talk to him for a few minutes. Very approachable guy. And in fact, I brought my book along and got him to sign it while we were there. I told him a little bit about my own experience, how I came to be there in Dallas listening to his conference. I'm going to share that a little bit with you. 2 years ago, I went to my brother's apartment to check on him since he had a chronic illness. No one answered, just a dog barking, but he didn't have a dog. Only then did I remember that he had moved out of this apartment down to the first floor in another building 2 years earlier. So I was at the wrong door, despite the fact I had been going to see him in his new apartment several times a week ever since he moved. That's when I realized that I was either having a stroke or the onset of dementia, and I couldn't decide which way I'd rather go. So I went to the emergency room so they could do an MRI and some tests to make sure I wasn't having a stroke. I told them I was hoping that it wasn't a stroke, that what it really was a memory deficiency due to what I suspected was a severe vitamin B12 deficiency, since I have a digestive disorder called Crohn's disease, which leads to severe B12 deficiency. And in fact, in the ER, they did the blood tests, and then sure enough, the B12 level was almost subterranean. There was a very high level of a toxic byproduct of when you don't have any B12. So that seemed to be the problem. What really got my attention is when I went to see my neurologist, and he said, yes, that's your problem. But he said, not everybody who has this problem gets better. Not everybody recovers just by taking vitamin B12. And that was certainly got my attention. So that's when I started doing some research and found Dale Bredesen's work. And I decided, well, I've got nothing to lose, so let me get on his program and see how this works. And so I've been on it ever since. And so that's what I shared with Dale Bredesen in Dallas, was this really did seem to work for me. And so I'm here to learn about it so that maybe I can help some other people who have problems along these lines. So, well, what about the details, Dr. Fox? Okay. So I'm borrowing quite a bit from Dale Bredesen's work, but you'll see that we've done some of our own work on this. His point is that Alzheimer's disease is a metabolic disorder of a particular protein called this amyloid precursor protein, and that the disorder arises from either genetic and or lifestyle factors, and that it's a metabolic disorder that affects the brain. It's a little bit similar to other metabolic disorders like type 2 diabetes. That's a metabolic disorder of sugar, which can have effects on your eyes, your kidneys, your heart, your brain. Or another metabolic disorder is if you have very high cholesterol. Again, that's a metabolic disorder that has a lot of effects on your heart and your blood vessels, and also, in fact, on your brain. So you can see that metabolic disorders don't necessarily confine themselves to one organ. They are systemic disorders, and we end up treating them systemically. So this is a slide from Dale Bredesen, in which from 20 or 25 years of working in the test tube, he's elucidated all these different complex metabolic pathways by which this amyloid precursor protein is influenced by all these dozens of different genes. Again, you don't have to memorize this, but just want to illustrate to you that metabolically this is complicated. So it's not like you can do one test and that answers the whole question. So we're going to, in this seminar this evening, go through some of what might be your risks and what you can do to mitigate these for yourself and your family. And as Ben Franklin said, an ounce of prevention worth a pound of cure. So the best way to deal with this is, before you have any memory loss issues, identify what genetic and lifestyle risks you may have so that you can then undertake a program to prevent them from developing. If you're already at the point where you're having some issues, well, better to understand and investigate them now rather than waiting another year or two when it'll be much more difficult to get back to where you'd like to be. So genetic risk. The genetic risk for Alzheimer's disease is primarily due to one gene called the apolipoprotein E gene. It comes in 3 flavors, E2, E3, and E4. Most of us have E3. And the incidence of the E3 gene is about 74-75% in the American population, probably similar around the world. I don't think ethnicity has a big impact on this. About 15% of us will have at least one copy of the E4 gene, and a few percent of us will have one copy of the E2 gene. Now, since we all get a gene from each parent, you can see there are a lot of different combinations, but the common ones that we see are you get an E3 from each parent, or the next most common, about 24% of us get an E2 from one parent and an E4 from the other. And then about 2 or 3% of us get an E4 from each parent. Well, the problem is if you have a copy of E4, that increases your risk of memory loss. If you have one copy of E4, your risk, well, if you have no copies of E4, you have about a 9% lifetime risk. You get one copy of E4, your risk goes up about 3 times to about 30% lifetime risk. If you get 2 copies of E4, you're looking at anywhere from 50 to 90% lifetime risk. So it's probably a good idea to figure out what your genetic risk is and to do so as soon as possible. So if you're in one of those groups, you can at least start to do something about it. Lifestyle risks generally fall into some of these categories, the familiar ones. They're the same risk factors that we have for a lot of other problems. Diet, having, oops, sorry about that, too much weight, not enough exercise, not enough sleep. So indeed, if you address some of these lifestyle factors to try to keep your brain tip-top, that'll probably help your heart, your blood pressure, and a lot of other things in the bargain. So let's talk for a second about stages of memory loss in Alzheimer's disease. Sort of stage 0 is when you don't have any problems, when you're young and healthy. As you start to develop some cognitive issues, the first thing is that you or perhaps your family member, your spouse, becomes aware that you seem a little more forgetful than you were before. But if you come to my office and we give you a standard memory test, and I'll show you that in a couple minutes, you can pass the memory test just fine. So it's possible to be impaired but still have a perfectly good test. If your score is below a certain level, we call that mild cognitive impairment. And if you're even more impaired, then you have what we term Alzheimer's disease. So these are the various stages. The test that we use is called this MoCA test. If you're anywhere, it has 30 possible points. If you're anywhere from 26 to 30, you pass the test. But that doesn't mean that you're okay, because maybe your spouse realizes that you're getting a little forgetful. But if you can pass the test, you only have subjective impairment. If your score is less than 26, we call you mild cognitive impairment. And beyond that, you have Alzheimer's disease. Most of those people have a score that's typically less than 18, but that's not what actually distinguishes them. What distinguishes them, by the way, this is the MoCA test. We give this in our office. You can find it online. You can take it a bunch of times before you come to my office if you want to make sure you get a good score, but that's not really why you're coming in. So I would say just come in and just take it. So the things that we use to evaluate patients is fourfold. What your symptoms and history are. We have a long questionnaire that you fill out when you come to the office, and that helps us to figure out where you are on that. We give you this memory test. It only takes 5 or 10 minutes. For everybody, we would like to get an MRI scan to see what the imaging of their brain looks like. We're fortunate enough to have Dr. Murray Solomon here this evening, who is a very, very experienced neuroradiologist who's going to spend some time familiarizing us with how the imaging of the brain informs us about memory loss. And then we have a long list of blood tests that we do. So this is that questionnaire that we do. We do this MoCA test, and we look at the brain MRI results with particular attention to a part of the brain called the hippocampus. And how's that doing? Is your hippocampus healthy? This is the hippocampus. It's way down here in the brain. And Dr. Solomon is going to give us a lot more information about that.
You heard about the importance of the hippocampi. What's important to state is that very early on, amyloid is deposited in the brain, but it may be 30 years before you're symptomatic. So if you do an amyloid scan, it may be positive, but you're cognitively normal. And it turns out some people with amyloid in the brain never develop dementia. We don't understand why that is yet, but there are some people who can deposit amyloid in their brain and they never have any problems. They may have what we call cognitive reserve. They have a PhD, they're mentally active, they're socially active, they exercise, they watch their diet, and that may forestall the development of disease. It turns out if you have a PhD, Alzheimer's is delayed by 10 years. If you're perfectly bilingual, that delays development of Alzheimer's for 10 years. So it may be important to start learning another language if you haven't done so already. And what we do with this technique is we measure the hippocampal volumes. As I mentioned, so very early on, perhaps even decades before people are symptomatic, amyloid is deposited. There's another protein that follows amyloid called tau, and one of the reasons why some of these drugs failed is the drugs eliminated amyloid, but they didn't eliminate tau. So that's one of the theories of why some of these drugs failed. But notice when you look at clinical function, the last thing to go, before memory loss, which is shown in purple, is brain structure, which is hippocampal volume. So the hippocampal volume is the last thing to go, decrease in hippocampal volume before dementia actually appears. So we pay a lot of attention to this. So if we were to start out with mild cognitive impairment, now not all patients with mild cognitive impairment go on to develop Alzheimer's disease. But if you look at year 3, for instance, 65% will be stable, and about 25% shown in green will develop dementia. And the question is, can we predict these 25%? Can we tell by looking at hippocampal volume which patients are going to go on to develop dementia? Now, when you compare clinically normal to diagnosed with Alzheimer's disease, it's fairly clear that these hippocampi are atrophied. They're much smaller here than they are here. The problem, however, is when you compare clinically normal to mild cognitive impairment, not so easy. So this is the reason why we need a computer to analyze the images and do volumetric measurements of the hippocampi. So if you start off year 0, and at that point, if you're 1 standard deviation above the mean for hippocampal volume, only about 30% of those, maybe 25% of those patients will go on to develop Alzheimer's disease. So if you have a hippocampal volume reserve, that perhaps buys you some time. Now, if you have average hippocampal volume, you're at the mean, now after 3 years, there's a 50% chance that you will have developed Alzheimer's disease. So this is a predictor of who's going to, it doesn't mean everybody is going to do this. It's a statistical test, but if you had a low hippocampal volume, you might be more aggressive about some of the conservative management that you heard Dr. Fox talk about. And certainly if you're 1 standard deviation below the mean, basically 85% of those patients will go on to develop Alzheimer's disease. So if we see somebody, and the hippocampal volume is corrected to your total brain volume, and it's matched to age and sex. So there's a large database this is compared to. If you're 2 standard deviations below the mean at the time you come to Dr. Fox's office, that's the time to be very aggressive because you're at high risk 3 years later of developing Alzheimer's disease. So we do this with a FDA-approved program called NeuroQuant. This was developed at UCSD. There's a national database that's used in academic centers called ADNI, the Alzheimer's Disease Imaging Initiative. And they've basically taken their information and they have commercialized it to produce this FDA product. And this is what we get. This is a NeuroQuant printout. And you can see here that the hippocampal volume, let me go back here, the hippocampal volume here is below the first percentile for age. That's bad news. But notice the other thing we can look at is lateral ventricular volume. There's another disease that can mimic Alzheimer's disease called normal pressure hydrocephalus, where the ventricles are way too large. So we can use this NeuroQuant to help us diagnose early Alzheimer's disease, but we can also look to see that the lateral ventricles are not too large. If we see the lateral ventricles exceeding the 98th percentile for age, we start to get nervous. Now, the inferior lateral ventricle is a mirror image of the hippocampus. As the hippocampus atrophies, the inferior lateral ventricle enlarges. So we use that as an internal check to make sure this number is actually accurate. So this should be very high when this number is very low because as you lose hippocampal volume, the inferior lateral ventricle enlarges to fill the space. So that's sort of an internal check that we have. And we get these curves, and we can show, and this goes all the way from ages 20 to 100. It's actually been dropped down to lower ages recently, but in the old form it was ages 20 to 100. And there are young people who develop Alzheimer's disease, who have genetic, you can develop Alzheimer's in your 40s if you've got some mutations, presenilin mutations. And you can see that the standard deviation curves are shown here nicely. So you have the mean, and you have 1 standard deviation above the mean, 2 standard deviations below the mean. You can see this patient really is in trouble. And this would be the time to be very aggressive if they're starting to lose cognitive function. We get other areas that we look at, so we're not just looking at the ventricle and the hippocampus, we actually get a large range of abnormalities. And these can be used for other diseases. But the lateral ventricle primarily for normal pressure hydrocephalus, the hippocampus for memory loss. Frontotemporal dementia would give us loss in the forebrain parenchyma. So we combine these techniques. We're doing neuroquant, ASL, visual checking of the scans to try to figure out what's going on. So I'll show you one example. This is a 75-year-old female with subjective memory complaints. That is, if you tested her with the tests that Dr. Fox talked about, the values would come out normal. But many times people who have subjective memory complaints will go on to develop objective memory complaints. So it's a sign, you know, I can't find my car keys may just be a senior moment, but it could also be early development of disease. So if you have one of these memory loss issues, we can look at your hippocampal volume and you'd say, well, this patient's got it's at the 92nd normative percentile for age, looks pretty good. So there's nothing wrong here. But this one data point may be inaccurate. So one of the things, because this is relatively inexpensive, we can follow these patients over time. In a normal individual, you only lose 0.3% per year in hippocampal volume. So it's almost, you can't see it visually, and it's very minimal in terms of computer measurements. So 0.3% per year loss is normal. So now 2 years later, the patient has worsening memory difficulties, and now there's a clinical suspicion that the patient's converted from subjective memory loss to objective memory loss. So we bring the patient back, and notice now the hippocampal volume has dropped from the 90s to 75. Now by itself, 75 is a normal value, but serially you shouldn't drop from the 90, 92 or 93 to 75 because we said you only lose 0.3% per year. So when you compare this, if you go from 92 to 75 in a 2-year period, that's bad news. And notice the other factors don't change very much. So that's a sign, this is a piece of information that says, yes, you are in trouble. You may have converted from subjective to objective memory loss. That, of course, can be confirmed clinically as well as with testing. So I'll show you another case. This is an 87-year-old male experiencing memory loss, bilateral severe gait weakness and falling, clinical suspicion for Alzheimer's disease versus hydrocephalus. Now, when you look at the brain, you can see the ventricles are markedly enlarged. I know many of you probably don't look at many MRI scans in a day, but we look at dozens. These ventricles are way too large. But is it really enlarged? Is it just my subjective opinion, or is there some objective measure? The other thing we look for is what we call transependymal flow of cerebrospinal fluid. The pressure in these enlarged ventricles is high, and it drives fluid out of the ventricles into the surrounding tissue. I won't get into the argument of why the fluid in the ventricle is black and the fluid outside the ventricle is dark, but it has to do with the fact there's solute in the ventricle, in the signal outside the ventricle. So, but I can then look at the hip neuroquant. So my subjective impression is that these ventricles are too large and this patient may have normal pressure hydrocephalus. But notice when I quantitate it, I correct for the head volume and I correct for age and sex. We're at the 99th percentile, more than 2 standard deviations above the mean. So this patient, and then we can also look at hippocampal volume. Now, there is a relationship between NPH and Alzheimer's. So one of the reasons why you want to correct the NPH, sometimes with a shunt, is that with very large ventricles, you don't clear the amyloid from your brain. And so there's actually a relationship. People who have NPH are more at risk for developing Alzheimer's disease. So it's something you want to pick up before the patients become symptomatic. So in this 87-year-old male, because the lateral ventricular volume exceeded the 99th percentile, but his hippocampal volume was at the 49th percentile, we would argue this is probably normal pressure hydrocephalus, a treatable cause of dementia with a shunt rather than Alzheimer's disease. And I thank you for your attention. I'll hand it back to Dr. Fox.
The imaging studies were then interested in laboratory evaluations. And as I said, we have a long list of tests that we do. And that's what we do for everybody. It's like the auto tune-up place, that advertises that they do the, 85-point checkup on your car. Well, that's what we have to do. We're trying to do a tune-up on your brain, and we need to look at every different aspect of it. And unfortunately, for those of us who get older, it's like when your car's got a lot of miles on it, it just needs more maintenance. So a few blood tests might be okay for you in your 20s, but when later on, you need a much more comprehensive evaluation. So when we take your history, your MoCA test, your memory test, your imaging studies, and your laboratory tests, we try to put all that together and fit it into this category system that Dr. Bredesen has worked out. And we're at this point trying to see just how well that classification works for our patients. But he has identified essentially 6 different types of Alzheimer's disease. These are not generally recognized, I think, by the Alzheimer's fraternity, but I think there's merit to his argument. So we're going to talk a little bit about these different types and how some of our patients fit into those. Briefly, he says there are some patients who have laboratory tests that indicate that they have chronic inflammation. Others are not inflamed, but they're deficient in something, like in my case, vitamin B12. There's a type 1.5 that's sort of in between these, and we tend to see that in people with type 2 diabetes. Type 3, where their brains are being poisoned, really, by some kind of toxic material. We'll give you an example or two of that. Another type where they have disease in the small blood vessels in their brain, and they're just not getting enough blood flow, and that's causing memory loss. And then the last one, the traumatic type, this is what the NFL is worried about their football players getting. Remember the boxers who used to be punch drunk? Well, now we understand that they have a traumatic encephalopathy. So the type 1, these people have evidence of chronic inflammation. It might be some kind of chronic infection. Interestingly, leaky gut can lead to chronic inflammation, and even chronic dental disease. All these have been identified as things which, if treated, people actually do improve in terms of their memory function. This type 1, these people are characterized by abnormal MoCA tests. They tend to be what we call amnestic. They can't remember things. There are other types that I'll talk about in just a moment. These people often have this genetic factor, this E4 version of the ApoE gene, and then they may have other family members. They may have siblings or parents, aunts or uncles who've had Alzheimer's disease. Their MRI shows the classic finding that Dr. Solomon discussed. Their hippocampus just shrivels up. And the hippocampus seems to be very important for memory processing. It's not all of your memory processing, but it seems like it's an essential piece. If you don't have it, you have a lot of trouble processing memory. These people will have laboratory tests showing chronic inflammation, and a couple of the ones that we key on are this one over here, CRP, and this one called C4A. Both of those seem to go up in these patients. So obviously those are among the ones that we test for everybody. Type 2, wait a second, let's go back. Type 2, the atrophic type, these people aren't inflamed, but they're lacking something that they need in order for their brain and their memory to work properly. So they will have memory loss, they'll have abnormal memory tests. And in fact, they may not really understand that they have any problem, but it's the family members who understand that they're having a problem. Again, they have the E4 gene is a major risk factor. Again, their MRI shows hippocampal volume loss. Their laboratory tests don't show those inflammatory changes. They show deficiencies in several factors that are important for memory function. And that's on that list of laboratory tests that I mentioned. And we'll talk about some of these a little bit later. The type 1.5, this is the one that we see in people with type 2 diabetes. And they have, the type 2 diabetes is an interesting thing because it causes inflammation, but it also causes atrophy. The inflammation is due to the fact that the elevated blood sugar, the sugar sticks to certain important proteins in the blood, and they become abnormal, and it turns them into pro-inflammatory factors. The atrophic effect is because the chronically elevated blood sugar causes the insulin receptors in the brain to be overwhelmed, and they just stop working the way they're supposed to, and you need insulin. In the insulin receptors in your brain help sugar get into the brain so that you can think. So when you wipe out your insulin receptors, you can't get sugar into the brain, and it just doesn't work as well. So these people also have the abnormal MoCA tests. They have the MRI showing hippocampal volume loss. If they also have E4, that increases their risk. And so for these folks, the blood tests we look at are this hemoglobin A1C, which is a measure of the amount of hemoglobin in your red blood cells that has sugar stuck to it chronically. They also have increased fasting insulin levels, so it's another thing we test for. The type 3, these people are different than those first 3 types that I described. They may have the onset earlier in life than other people, and they have some kind of chronic toxic exposure. The classic one was mercury. Remember Mad as a Hatter? Well, in Old England, the hatters used to lubricate the hat pins with mercury so they would slide through the leather more easily. And then they would put a bunch of pins in their mouth so they would be convenient. They, gave them another hand to work with. Well, all the mercury in their mouth caused them to become mad as a hatter. We don't see that anymore, but it's interesting that you still see people with mercury poisoning, and if they're eating a lot of fish that are caught from waters which have a lot of industrial mercury pollution. Yeah, and amalgam fillings is another risk factor. Now, my dentist says that the dental people deny that that's a possibility. Yes, there are those. There is a school of thought that if you have 3 or more amalgam fillings in your mouth, that maybe you should at least get tested for mercury, or maybe just have them replaced with plastic. Molds, there are a number of molds that produce toxic materials. And Lyme disease, we have Lyme disease here in California. I had a lady at my last seminar here who told me she had Lyme disease a number of years earlier. It's not the tick that has the toxin. The tick has a little, I don't know, you call it a germ. It's a spore, or what is it? I forgot. It's a bacterium. And the bacterium itself produces the toxic material. So anyway, all these are toxins that can cause memory loss. Interestingly, these people, they typically don't have the gene for this because they've been hit from some other direction. And their MRI will show not just effects on the hippocampus, but much more broadly within the brain. So a couple of the laboratory tip-offs, they seem to have a low ratio of zinc to copper. They may also have hormonal abnormalities. And if you do the test and look for toxins in the blood and urine, you may well find them, but it sometimes takes very specialized testing to find those. Type 4, the cerebrovascular sort of dementia is actually probably relatively common. And since we've been doing MRI scans at Dr. Solomon's, I've noticed a number of his reports suggest that maybe this person has some ischemic cerebrovascular disease. And so this seems to be not terribly uncommon. They have memory loss, they have abnormal MoCA tests. It's not clear that ApoE4 is a risk factor, but for some of them, actually E2 is a risk factor. If you get 2 copies of E2 from each parent, you actually develop a lipid disorder, and will put you at risk for this sort of thing. The MRI scan may show white matter changes, and a PET scan that's actually negative for amyloid. So you don't have to have amyloid with this. And the lab tests may show lipid disorders such as elevated cholesterol. And in particular, we're looking for damaged lipid components, damaged cholesterol. It may be that it's not how much cholesterol you have, it's how much damaged cholesterol you have circulating that trashes your coronaries and your brain. So we actually pay more attention to how much damaged cholesterol you've got, damaged lipids. So some of the little data from patients that we've seen so far. We've been doing this for about 2 months now, and so we don't have a lot of patients, but we've got about a dozen of them that we've got some data on. So you can see their ages range from early 70s to late 80s, mostly in the mid 70s to 80 range. By sex, we have more women than we do men. And it's a small sample, so I don't want to generalize too much, but my impression is that the women tend to have worse MoCA scores than the men do. Just a second, Ron, I'll get your question a little later. In terms of MoCA tests, remember 30 is a perfect score. If you're above that level, but you're having symptoms, you're in that subjective cognitive impairment group. So between this red dot and this red dot, those are the people with mild cognitive impairment. So we've got several of those. And we've got a couple of folks who are clearly well into the Alzheimer's range.
When do they take your driver's license away?
When they catch you. In terms of hippocampal volumes, we can see we've got quite a range. We got one up here at 95%, and we got one down here at 1%. The hippocampal volumes don't always correlate with the MoCA scores. I find that very interesting. I have one lady who's got a hippocampal volume that's up here in the 70s, and her MoCA score is down in single digits. But she's one of the ones that the MRI suggests may have some vascular disease. In terms of the ApoE genotypes that we've seen, we have one E2, E3, 2 E3, E3s, and actually 3 E3, E4s, and one patient over there on the far side, who's an E4, E4. Now, she's quite a functional person. She's had an almost perfect MoCA score. She had a 29 on her MoCA score, and quite functional. And I'm not exactly sure why she came to our seminar, except she's a friend of mine, so maybe she just came for that reason. But what do you know? She turns out to be an E4, E4, and on her MRI scan, her hippocampal volume is down to the 16th percentile. She's 1 standard deviation below the mean. So she is at substantial risk here. As I told her, you've got 2 flashing red lights, and even though you don't have any problems right now, we will have to see what we can do to keep you tuned up. So this is that parameter that we use for looking at inflammation. Most of our patients don't seem to have that problem, but we have one, and especially another one, that do seem to have some inflammatory process going on. Fortunately, this lady here, when we saw that, we started her on a simple over-the-counter supplement, and a month later when we checked it, she's actually down here now. So I hope we helped her. For whatever reason, she's in a much better place now than she was when she started. And of course, she didn't know she had that problem when she started. Our C4A is another inflammatory measure. And again, we've got a couple people who are elevated, but most not. Hemoglobin A1C, this is sort of the cutoff. If you're below the red dot, you're okay. If you're above it, maybe we have to pay some attention to you. And this dot here, that was at baseline. I actually have some follow-up lab on her from just this week after we started her on treatment for that problem. And she is actually now almost right at the red dot. She's definitely correcting, so that's nice to see. Homocysteine is a toxic byproduct that builds up in your blood if you lack vitamin B12, like I did. My homocysteine level is the highest. It's twice as high as any other that I've ever seen. It was sky high. It was astronomical. It builds up when you're deficient in vitamin B12 or folic acid or a couple of other vitamins. Deficiencies can cause this. So as you can see, we've got quite a few people who have levels that are above where we would like to see them. And so most of these folks are going to get a recommendation for more vitamin B12, more folic acid. We actually measure those so we can see where people are starting from, and then we can follow those up to see if those levels are improving and if their homocysteine level is coming down, which it generally will. Now we get into really interesting controversy that Dr. Bredesen sort of first alerted us to. He pointed out that women seem to be more affected by this problem than men, and that of the people who get Alzheimer's disease at young ages, like late 40s, 50s, early 60s, a lot of those are women, and the onset of their difficulties seem to occur after menopause. So he raises the question of does a sudden loss of estrogen support predispose some women, particularly if they have genetic or other factors, to memory loss? So we've been very interested in measuring estrogen levels. And of course, our women are all well postmenopausal, so they all have very low estrogen levels. And in some cases, we've suggested that they start taking estrogen replacement, excuse me, if they're having low MoCA scores or low hippocampal volumes, or they have other risk factors, so that we can see whether that is effective in our hands, as Dr. Bredesen claims it has been in his hands. But that's a controversial one. There's a lot of controversy about hormone replacement in women because there are those who feel that it also has some downside to it. But you have to sort of balance. Losing your memory is a big downside also. Thyroid status seems to be another important factor, and we measure that by looking at 3 different tests. This TSH, you want to be below the red dot. You want to be between the red dots. We've got a number of people who are above that. For free T4, you'd like to be between the red dots, and we have several people who are too low. And free T3, we also have a number of people who are low. The people who are low on these two tend to be the people who are high on those. So for a number of people, we've suggested that some thyroid medication may be useful to them, particularly, again, if they're in the groups who are having memory difficulties or hippocampal volume difficulties. Vitamin D seems to be an important vitamin because it's one of the few vitamins that actually enters brain cells and enters the nucleus of the cells, and it acts like a hormone as well as a vitamin. Vitamin D deficiency seems to be widespread and related to a lot of difficulties. So we would like vitamin D to be in this level. Most people are sort of low on that, so we often suggest that they supplement with some vitamin D. Switching gears for a moment, I just wanted to show this, that a lot of people take a very superficial approach to diagnosing and treating this disorder and don't do this in-depth evaluation. And it turned out that Chris Christopherson was one of the people who was a victim of that sort of superficial evaluation. He was diagnosed with Alzheimer's and carried that diagnosis, I think, for even a few years. And somebody finally was intellectually ambitious enough to ask themselves, well, could there be anything else going on here? And what do you know, he turned out to have Lyme disease. And he got his Lyme disease treated, and what do you know? It's a miracle recovery. Yes, that's a bullet dodged, right? So just because you're wealthy and a celebrity doesn't mean that you can't fall through the cracks on this one. So what I'm going to suggest is that, like Chris Christopherson, you might want to look for your own miracle. And even better would be to start looking into your risk factors before you need a miracle. That is, anybody age 45 and up should probably have their MRI scan done, because as Dr. Solomon said, we don't really know what's going on with your hippocampal volumes until we have 2 points. You know, are you the same now as you were 5 years ago, or have you dropped during that time? So a good time to get your first MRI scan would be while you're young and healthy and still have all your faculties. And that would also be a good time to do all of your lab tests, and especially to get your genetic test to find out if you are at risk of one of these early onset types of Alzheimer's. Well, Dr. Fox, that's a long list of tests and scans and so forth. What's it going to cost me? We have found that most of this is being covered by insurance. The one exception to that, I guess, is I have one patient who came to me from Kaiser. Her Kaiser benefits obviously don't follow her outside the Kaiser system, but Kaiser obliged us by doing a lot of the laboratory tests, the ones that they could do. The family had to pay out of pocket for some of the tests that Kaiser doesn't do. But we try to get a cash price discount for them with the laboratory. And the Kaiser MRI scan wasn't really up to snuff, and so they ended up getting their MRI scan done at Dr. Solomon's facility. Cash price there, $400, which when you think about what you've got invested in your brain, that's actually kind of small potatoes. I mean, this is Silicon Valley. This is where people make their living with their asset that's between their ears. You have fire insurance to protect your house and car insurance to protect your car, and something to keep your an asset protection plan for your brain is probably money well spent. This is the checklist that I use for people when they come to see me in the office, and as a result of all those tests and everything else, this is the checklist of some of the different medicines that we use: thyroid medicines, estrogen, that's ones for diabetes, various different vitamins. We measure all those levels, and if you're not where we'd like you to be, we check that box. Some of the minerals: magnesium, zinc, selenium, and various other supplements. For some of these prescription medicines, some of them, like the estrogen, can be as much as $120 out of pocket at Rite Aid, but we'll give you the Good RX coupon, which you can see it saves you a lot of money. That's a great website to go to for any of your prescriptions to try to save money. So this guy just says, well, I'll have an ounce of prevention. That's what we're selling here. So the Bredesen program seems to help at least some younger people with some types of memory loss to prevent further loss and to restore some memory function. In some others, particularly when the loss is still early and mild, recovery from more advanced stages of memory loss. In older patients, while possible, remains speculative, and we'll just have to see how that works out. Why is it important? Well, if you ask Nancy Reagan and Chris Christopherson and a lot of other folks who've had to live with this, they'll tell you if this can be prevented, that's a lot better than having to live with this problem. So I think I'll stop there, and thank you all for your patience. You've been very good. Thank you. So I'll be happy to take some questions. Let's take 2 or 3 from the audience, and then I'll be happy to speak to you individually. Dr. Kite.
Yeah, I think that data, because you only have a small amount of patients, but as you know, well, as I know, that most of the patients I see are women. So I bet most of the patients you saw there were women. They live longer, so that overloads that part. So I don't think the data regarding, and I don't know what Bredeson's data is about the females versus males. God's will is the old man wants to have his young, beautiful wife take care of him as he parts along, you know that. But that's really the data that we have is mainly women, and there are more women that are born than men anyway.
Yes. And when we were here a couple weeks ago, your partner in your office, Dr. Demore, was here, who is a gynecologist, and he offered us his view that in his gynecology practice, this is a theme that comes up recurrently with his older patients. And in his decades of practice, it's been his experience that the women who are on hormone replacement don't seem to have as much difficulty as the ones who are not on replacement. So we'll see how the data develops.
It's also the brain study, the mentality. The woman, in my experiences, and I think that's the truth, is if a woman has a problem, she wants to go find out, she go to a doctor, whether she's working, where she's uncomfortable, et cetera, whether she has money or not. The guy doesn't want to hear about it. If he can't hear, he says, turn up louder or else don't bother me. And they say the usual, for example, the usual place where a man puts his hearing aids, a woman will wear it, a man puts it in the drawer. So we're really talking about, generally, if you're honest, about the difference between men and women.
But where the men end up coming in is when the wife tells them, well, you're going in. So at some point, they have no choice. Yes, sir.
For quite some time, there seemed to be a lot of focus. For quite some time, there seemed to be a lot of focus on plaque. And I see any reference to amyloid, I'm assuming that has to do with plaque. So based on the presentation, I guess that's just one of the factors, and maybe not to be that emphasized.
So for those of you who want to delve into this, I would recommend Dr. Bredeson's book. You can get it from Amazon. It's about $16. And he has a rather involved and different view of amyloid plaque. And he studied the biochemistry of the amyloid protein quite extensively, and he discusses this quite a bit in his book. And he points out that the amyloid protein can go down a couple of different paths. One of those paths is it can turn into plaque, but there are other paths that it can go down that actually help the brain to function and to repair itself. And which path it goes down will have to do with both those genetic factors and also a number of other factors like diet, exercise, vitamins, and all those kinds of things. But he has an interesting take on the plaque. He says that it may well be that the plaque is not the cause of the memory loss, but is merely a reaction to the brain injury that's causing that is that the plaque is actually a protective thing that attaches itself to the part of the brain that's being damaged by whatever else is going on. So the analogy is a little bit like we don't automatically assume that firefighters cause fires just because you always find firefighters at the scene of a fire. Sometimes they're there to put out the fire. And that's his argument as to why the hundreds of millions of dollars that the drug companies have spent fighting plaque have never worked, because they're just fighting the firefighters. They're not really fighting the fire. Anyway, thank you all for your patience, and I'll be happy to take any other questions that people have.
Did you have a handout or something?
We don't, but these gentlemen have been kind enough to come here and videotape this tonight, and we're going to edit that and put it out, like on a YouTube or something like that, or on our website. So if you give us your information, we'll send you that link.
Okay, but you don't have like a business card or something?
We have cards, yes. See Patty for all those questions. Yes.
Can I ask a question? So I noticed when you had I think there were 5 categories.
Well, yes, but
Roughly.
there's actually
So
6,
one,
but
1, 2, 3.
yes.
Okay, so I know this one was toxic related, so it's environmental. One was vascular, and then there were 3, and the one common thread I saw with those first 3 was family. And so I'm
family
wondering-
history, the
family
genetic.
history, yeah, genetics. So I'm wondering, because I have a plethora of this in my family, so I'm wondering how that weighs into it, how that factors in.
Yes. So if you have anyone, and particularly if you have several people in your family, I would highly recommend that you get the genetic study to see where you are. And perhaps other people in your family tree should consider that also. The statistics are, remember, about 3/4 of people don't have a genetic risk, but they still have a 9% lifetime risk of Alzheimer's disease. If you have 1 copy of E4, which is about 24% of the population has 1 copy, your risk goes up about 3-fold. It goes up to close to 30%. If you have 2 copies of E4, which is about 2 or 3% of the population, now your risk is north of 50%.
And then how old was your friend who had the double E4?
She's in her mid-70s.
So she's probably an anomaly, you think, or?
I wonder. There are certainly the people who are double E4 positive have been known to have onset in their late 40s and 50s. So maybe she's been living right because she's in her mid-70s. But on the other hand, her hippocampal volumes are down to 16%. So it could be that time's running out on that.
Okay, thank you.
Yep.
Thank you, Doctor.
Is the test a blood test?
Yes. Yep.